Hello, everyone. Greetings and welcome to Oral Pathology 360's Dentistry Special Series. I'm Dr. Mandana Donahue, founder of Oral Pathology 360, and it gives me great pleasure to have you all here. Today, we are going to be talking about role of physiotherapy in oral cancer recovery, which is very rarely discussed. But before we do that, I have some sad news. It is with a very heavy heart that we commence today's session. We are mourning the loss of Professor Johnson. He was a luminary oral pathology and pathologist and a cherished mentor to many. All of us remember him from the conferences, his warmth, his approachability, and his immense knowledge in many fields, and of course, including oral cancer, and also his care and his dedication to uplifting the overall education of dentistry. We in India, of course, have even more fond memories of him because he was almost there in every one of our conferences. And he has had great impact on us, on our association, and on many of us. And we will definitely cherish those memories and those times. And in the meanwhile, let's just spend a moment remembering him before we proceed. Our thoughts are with him and with everyone who was close to him, his family and friends, everyone that he cared and who cared. Well, I can truly say he will never be forgotten. But to go on as we should, today we are having a talk on physiotherapy, and our guest, I'm very excited to tell you, our guest is someone who has already about 21 years of experience, and a lot of it has been on management of patients with cancer. Dr. Rushill Tanna is currently working at HCG Cancer Center in Mumbai, and his many achievements, including publications, talks, and even some patents he is working on, all relate to management of patients with cancer. With that, let me bring him in. And yes, welcome, Dr. Rushil. It's marvelous to have you here.
Hello, good afternoon, one and all. Hello, ma'am.
Hello.
Thank you
Good
for having me.
afternoon. Oh, it's our pleasure. And it's a topic we rarely really deal with much in dentistry, but it is very essential. So it's a good thing to have you with us. And we will be listening to the lecture. Everybody remember, you have to put in your questions as usual in the live chat, and we will have a discussion afterwards. But I did forget one thing, and I shall just say that we have a lot of other lectures in our special dentistry special series. So these are just a few. Please do go find the playlist and check out what interests you and watch it. With that, let's listen to the lecture and then come back.
Good afternoon, one and all. My topic for today is Unveiling the Hidden Potentials of Physiotherapy in Oral Cancer. The following are the contents of this session, starting with introduction, oral cancer statistics, epidemiology and risk factors, screening of oral cancer, diagnosis, medical management, and physiotherapy management. Starting with the introduction, as we all know, cancer is an uncontrolled cell growth which starts almost anywhere in the body. Cancerous tumors spread and invade nearby tissues and can travel to distant places in the body to form new tumors, also known as metastasis. Oral cancer is nothing but cancer developing in any part of the mouth, including the tongue. As we all can see in the diagram, it very evidently shows the common site of oral cancer. Moving to the statistics, oral cancer is ranked 6th among all the other cancers, India being the major contributor in oral cancer. In India, the cancer diagnosis usually happens at a later stage, due to which there's an increased mortality. The map shows us the cancer spread is present all over India with a mean age group of 60 to 69 years, leaving the 5-year survival rate around 20% only. Owing to the epidemiology, squamous cell carcinoma contributes majorly to oral cancers, that is, 84 to 97% commonly results from potential malignancies or normal epithelium. The role of human papillomavirus is a common risk factor for squamous cell carcinoma, common amongst male as compared to females, and it is 6 times more frequent among smokers than in non-smokers. The bar diagram shows us the gender distribution among the smokers in developing and in developed countries, with male population being on the higher side on the developing as compared to the female population, and developing countries being on the higher side than the developed countries. Now, the risk factors. As we all know, tobacco consumption in any form is a prime cause of cancer, while the others being excessive alcohol consumption, poor oral hygiene, nutrition deficient diet, sustained viral infection, and exposure to carcinogens. Our next slide is on the presentation of cancer. It presents with a locoregional symptom like a non-healing ulcer, pain, bleeding, voice change, lump that is visual or palpable, patches over the tongue or over the mucosal layer, direct inspection, palpation during a routine dental examination is recommended. Moving to the screening of oral cancer, the 8-step screening process to be done with all the sterile precautions starts with the gingiva mucosa, moving on to the lip, buccal mucosa, anterior gingiva, hard palate, soft palate, tonsils, floor of mouth, and last, the lateral border of the tongue. Post screening, the next step is diagnosis. Not going into too much details, the image is doing justice of mentioning all the available diagnostic tools for diagnosis of cancer, starting from the physical examination to the histopathological examination. Moving to the oral cancer treatment, the aim is always to maximize locoregional control, minimize the functional loss and cosmetic alteration, and improving the quality of life of patients and improving the survival rate. Treatment options available are surgery, radiation, and chemotherapy, the classic trio used for cancer treatment, where surgery and radiation are used for curative treatment and chemotherapy is used to prevent secondary primary tumors. All the three can be used together or can be individually used based on the stage and type of cancer. Moving to the surgery, neck dissection surgeries, starting with radical neck dissection, leading to a major functional loss as sternocleidomastoid and spinal accessory nerve along with all 5 levels of lymph nodes are dissected. With recent advances and efforts to minimize functional loss, we have 3 types of modified radical neck dissection surgeries, type 1, 2, 3, each having some or the other anatomical structures spared for better function. Now, you all must be thinking, why is all of this type of surgery cancer, staging, all of it necessary from a rehab perspective, right? So let's unfold the rehab or the physiotherapy aspect of it, starting with the principles. So we have the principles of physiotherapy in cancer. They are categorized into pre-treatment, active treatment, maintenance, post-care or remission, and palliation, or they can be compiled under the headings of restorative rehab, supportive rehab, preventive rehab, and palliative rehab. Let's get started with the assessment. Starting with history taking, it becomes of prime importance in an inpatient and outpatient setting. The next being respiratory examination, usually performed in a pre and post-operative setting in order to maintain the chest hygiene. Musculoskeletal examination helps to find out physical limitations if the patient have. It also helps to find out neck and shoulder range of motion pre and post surgery and the status of the mouth opening pre and post surgery or pre and post RT. Head and neck examination gives us a detailed assessment of the oral cavity, usually performed pre and post operative and pre and post radiation therapy. Gait and posture assessment becomes of prime importance in patients undergoing or underwent surgical resection post cancer treatment. Functional assessment in patients helps us to find if the patient is mobile or immobile, figuring out the risk of DVT. Flaps and graphs, if used, help us to plan the rehab accordingly. For example, a PMMC flap, that is pectoralis major myocutaneous flap, would hamper with the shoulder range of motion. Similarly, a fibula bone graft would hamper with the weight bearing of the patient post-operative, and prescription of assistive device would become of prime importance. Moving on to the next, that is lymph node examination. If the lymph nodes are resected during surgery, a plan for lymphatic management becomes of prime importance. Other examination includes neurological examination and cardiac examination if the patient has a previous history of any neurological deficit and similar to the cardiological examination. The following are the goals of rehab in oral cancer patients. We'll see all of them one after the other in detail. First being pain, a non-pharmacological management is performed by the physical therapist. The management of pain can be divided into physical medicine and modalities, psychological intervention. It includes counseling, support groups, and the third being complementary and alternative medicine, that is cognitive behavioral therapy, hypnotherapy, acupuncture, etc. Therapeutic modalities used in cancer by the physical therapist are mechanical modalities. These modalities help to improve circulation, increase the range of motion of the joints, modulate pain, decrease or increase or control edema, whatever necessary, stabilize an area that requires temporary support. Mechanical modalities used for oral cancer treatment include compression therapy, compression bandaging or garments, and gravity assisted compression that includes standing frames or tilt tables. Electrotherapeutic modalities are next. Electrotherapeutic are a broad group of devices that apply electric currents to the tissues. The indications for usage are as follows: assist in functional training, assist muscle force generation and contraction, decrease unwanted muscular activity, increase the rate of healing, wound healing, and soft tissue healing, maintain strength after surgery or after injury, modulate or decrease pain by blocking the A beta fibers, reduce or eliminate soft tissue swelling. A few examples of electrotherapeutic modalities are biofeedback, iontophoresis, ultrasound, therapeutic ultrasound, low-level laser therapy, electronic stimulation, transcutaneous electronic nerve stimulation, and matrix rhythm therapy. Starting with biofeedback, it's a technique of gaining better awareness of the physiological functions using electronic or other instruments. Iontophoresis, it is a process of passing a weak electronic current through the skin or through the dermal layers. Therapeutic ultrasound is used as a treatment modality in physiotherapy care. Low-level laser therapy has found to be a boon in patients with oral mucositis post or pre or during radiation therapy. Electronic stimulation or nerve stimulation are used for patients with facial palsies, commonly in patients among parotid tumors who develop facial palsies. Transcutaneous electrical nerve stimulation is used as a pain moderation modality, can be administered post-operatively for pain management. Matrix rhythm therapy has come to light and can be used for pain management as well as managing radiation-induced fibrosis. The therapeutic exercises. It can be either land-based or water-based. Exercise prescription is done using the FIT principle. FIT includes frequency, intensity, time, and type. So land-based exercises include aerobic exercises and strength training exercises. The image truly shows us all the aerobic type of exercises like jumping, running, swimming, cycling, and walking. Strength training exercises are the exercises which enhance the strength of the individuals and improves the strength and endurance. It includes strength training and resistance exercises. Aquatherapy or water-based exercises include aquatic treadmills and aquatic cycles, and Tai Chi, that is one of the relaxation exercise which is shown to have a good result in cancer patients. The next is effect of exercise on health related outcomes in those with cancer. This is given by American College of Sports Medicine, ACSM, which is found to be a gold standard for exercise prescription. So they have found strong evidence in patients with cancer related fatigue, health related quality of life change, physical function, depression, anxiety, and lymphedema. So they have prescribed aerobic exercise, resistance only, and combine of aerobic and resistance. They have mentioned the dose for each. Please take a screenshot for further reading. Coming to chest hygiene, pre and post operative chest care becomes one of the most important part. The techniques used to maintain chest hygiene are as follows: chest percussion, vibration, postural drainage, deep breathing exercises, use of respiratory devices like incentive spirometry, flutters, acapella, not very frequently used in oral cancer patients. Nebulization, suctioning, and tracheostomy care are also important. Neck and shoulder range of motion exercises. They became of prime importance depending on which structure is dissected during the surgery. Is it the sternocleidomastoid, which is a neck stabilizer, or spinal accessory nerve, which leads to drooping of the shoulder or trapezius weakness? Neck stiffness and shoulder dysfunction are common among the postoperative dysfunctions achieved. In our setup, usually shoulder range of motion exercises are started on postoperative day 1 and neck range of motion exercises are started after a surgeon's go-ahead is received, but usually at around postoperative day 5. Early mobilization also have a positive impact on patient's physical and mental well-being. Mouth opening becomes a problem post-operatively and if not addressed, even post-radiation therapy. The treatment options available are shown as below. The first involves mouth opening exercises. These are to be taught to the patients and can be performed by the patients at home in front of the mirror. The second one being mobilization if in case there's a bony restriction which is present. This is called as joint mobilization for temporomandibular joint. The second one being the use of jaw stretcher, also called as therabites or orabites, usually very easily available in the market and prescribed to the patient for passive movement of the mouth. Research suggests the use of matrix rhythm therapy over conventional therapy on patients with radiation-induced fibrosis or radiation-induced trismus, which is one of the commonest problem occurring in patients after RT. This is one of my research. If anybody is interested in reading further, please let me know. The next is lymphedema in oral cancers. Lymphedema is a swelling which is caused by the damage or the obstruction of the lymphatic fluids. Based on the recent research, 50% of the head and neck cancer patients develop lymphedema. Treatment of head and neck lymphedema can be managed using complete decongestive therapy, which includes manual lymphatic drainage. A gentle skin stretching massage is being performed by the therapist standing at the head end. Compression therapy. The image shows the compression therapy or the chin strap to be used by the patient. Exercises. Neck range of motion exercises to be prescribed post-operative and post-RT in order to make sure lymphedema is prevented. Skincare. Skincare becomes a primary importance as the skin becomes dry because of the excessive stretch caused due to the lymphedema. So moisturizing skin is of utmost importance. Radiation fibrosis syndrome, also known as an evergreen menace of RT, a major cause of long-term disability following radiation therapy. The three phases of radiation fibrosis are as follows, starting with the acute phase. Acute phase is during the radiation therapy. Early delayed phase, that is by the end of radiation therapy, and late delayed phase, that is even after the RT is over, it has a long-lasting effect. The normal time used for the treatment of radiation fibrosis is 6 to 9 months or over a year. From the point of view of the physiotherapy rehab plan, gentle stretching becomes a major part of rehab as it works on the principle of applying low load and getting a prolonged stretch. Tongue mobility is affected in patients with glossectomy cases, let it be hemi, partial, or near total glossectomies. Early reference to speech and swallow therapist. From the physiotherapy point of view, tongue isometrics using an ice cream stick or using your own finger can be helpful. Tongue mobility exercises can also be helpful. Gentle exercises of the tongue, moving tongue in and out, right to left, up and down can be helpful. Speech language pathologist can help to improve the speech, and oromotor stimulation are also used in patients with tongue cancer post-RT. Moving to scar tissue management, the aim is always to minimize the scar and to improve the motion or to improve the function. So scar tissue can be managed by scar tissue massage, which can be done by the patient himself or herself or can be taught to the attender. Ultrasound, therapeutic ultrasound can be used to loosen the skin surrounding the scar, and laser can also be used as it has shown to be a beneficial effect in scar management. Let's summarize the role of physiotherapy in multidisciplinary team. Pre-op reference for a better post-op care. Pre-op assessment and treatment includes respiratory examination and intervention to improve chest hygiene and musculoskeletal examination for better mobility and neck and shoulder range of motion. Post-op evaluation and treatment include chest clearance techniques, as we've all seen, chest physiotherapy, postural drainage, Early mobilization, neck and shoulder range of motion exercises. Shoulder range of motion to be started on POD 1 and neck range of motion exercises to be started as we get a heads up from the surgeon. Addressing the functional impairments which are caused after surgery and patient education. A pre-rehab, a pre-radiation therapy physiotherapy reference becomes of utmost importance as we would want to have minimal functional disabilities post a radiation. Patient usually have difficulty in mouth opening due to fibrosis. So mouth opening exercises are prescribed pre-radiation therapy and to be continued throughout the radiation therapy. Moving on to the post-radiation therapy. Post-radiation therapy, achieving maximum mouth opening and enabling maximum function are the major goals of a physiotherapist. So let's enhance the quality of life of the patients through rehab. Thank you all for your active participation.
Yes. Thank you. That was very informative and very complete. It's really not a role we think about much, and not we are really not taught also in the industry about the role that physiotherapy plays. At least when I studied, that was a long time ago, I agree, but that time it was not there. I don't know if it is now added into the syllabus. So let's see if anyone has any suggestions or questions. So far, nothing has come. So, what do you find is the most challenging part of managing patients who have had oral cancer?
I feel radiation-induced fibrosis, as we talked about the radiation fibrosis syndrome, that I feel is a major challenge for all the physiotherapists also and for the treating surgeons as well.
Yes, that would definitely, and I think it hampers a lot the recovery, in the sense
Recovery, yes.
the movement itself is reduced. It interferes with so many things that really socially are very important, because speech, eating, that community sense of community, and all of those actually make a lot of difference, I think. Yes.
We already have a lot of stigma about oral cancer, and
Yes,
these things kind of hamper with the daily function and with the cosmetic appearance of the patient. So
that is true. Something
this was,
that's
as it is,
very often. Yes, this was very short.
a
I know,
very
I told you to
concise
keep
and
it
just,
short.
yeah, this was, yeah. So this is just kind of an introduction to how we take ahead. If we,
That is
these
true.
are kind of one chapters of the book. If we go ahead explaining all of them in detail, it'll become a bigger session then.
Definitely. But this was an introduction. We can always have a bigger session later. Yes.
Sure, ma'am.
The idea was to introduce the topic, at least get people aware, you know,
Yes.
and then when we have a longer discussion, people will know what to expect. That makes it easier. Yes, we have one comment from Professor Hiller. Okay, we tend to not think much about physiotherapy as diagnosticians. From which specialists do you mostly get your referrals?
So I would say we kind of diagnose a few things, obviously related to the musculoskeletal origin. And my referrals usually are from surgeons, oral maxillofacial surgeons, radiation therapists, radiation oncologists. So all of them refer me, including chemo and chemo, immuno, all of them. So it includes all the specialty, particularly surrounding the cancer treatment. So we can consider medical oncology, radiation oncology, oral maxillofacial surgeons, head and neck surgeons, all of them.
So basically, people who are involved in the treatment, in the management
treatment
of the cases. That's true.
cases. Yes,
Sorry. Yes. How long does the physiotherapy go on?
depends case to case, patient to patient. So, for example, if we have a patient who's just got treated or who's just got operated, the rehab would take almost a month's recovery time to get back to normal. And similarly, case if we take a case of a patient who's just gone out of radiation or just completed radiation, for that patient we would give 1 month's kind of cool down phase in which the body recovers back to normal, the skin recovers back to normal, and then we call them. So it's a long, we can say, a long standing physio rehab to go on along with your treatment.
True. Then I think anyway, physio is rather long. Physiotherapy is really a rather long thing. Let me see. But see, we have already made one impression.
Yes.
So Professor Hiller is from South Africa, and like he
Okay.
says, now they have a monthly, I think, case discussion
MDT.
of head and neck.
Yeah, yeah.
Yes. So he is going to bring it up there. So that's going to be
Yes,
that
yes,
many more
please.
people who will now
More, more.
think, yes, that is exactly the purpose of this. All right.
We at HCG also have MDT meetings happening. So it's obviously like he's saying, it's organ wise or disease wise. It's head and neck, breast, gynecological, all of that. So it's divided. So I
Okay.
think all of them are taken care by me when they come for rehab.
Yes. That must be a lot of work.
Yes.
I know. We have, okay, we have a question from Dr. Ruchi. Please explain about matrix rhythm therapy, which you mentioned.
Okay. So matrix rhythm therapy is one of the modalities which I have used it in my research project, or we can say in my research for the patients with radiation induced fibrosis. So, radiation induced fibrosis is usually a long standing problem which all the radiation oncologists were facing. And we've tried to kind of do a pilot study. So, in the pilot study, we've used two groups, one group being the conventional treatment, and one group being the matrix rhythm therapy group. So in the conventional treatment, we placed 15 patients, and in the matrix group, we placed 15 patients. So both of them had long term. If we say, then the long term for both of the patient, both of the groups were kind of the same. The results and the outcome were the same. But if we look at the efficiency and patient outcome, patients were feeling better in the matrix rhythm therapy group. So matrix rhythm therapy was used in and around the buccal area, the whole of the buccal cavity from outside, obviously, and the neck and the sternocleidomastoid. So we were trying to release the cheek, the neck, and some amount of the shoulder in case to have a better mouth opening. Our end goal was to improve the mouth opening of the patients because all of them were head and neck cancer patients, undergone surgery, and undergone radiation therapy. I hope I've justified and I've answered Dr. Ruchi's question.
And she'll comment, I'm sure, if she needs any more ans- la- description or clarification. Okay. Yes, I. There seem to be no other comments or. No, I think she's Satisfied with the answer.
Satisfied with the answer. Yeah.
Yes. So in physiotherapy, what I would say is that actually, in some ways, like probably just like doing any other exercise or any other health enhancing movement, uh, I think besides just helping with the local problems, when
Problems.
you're dealing with these patients, do you also give anything that would help with the general health? Do you
General
suggest that
health.
they do anything for the general health?
Yes, yes, yes. We ensure that they are undergoing aerobic training, like they have to undergo walking or any kind of activity which they do for recreation. Let it be, for example, a patient is a marathon runner. So, getting back to marathon running or starting with a sprint or starting with a walk is always enhancing their physical ability. Along with that, we kind of help them and provoke them to do a lot of yoga or pranayams, so they are quite being energized throughout the day and not feeling down since they start their day with a negative thought. So along with the physical health, we are managing the local pains, we are managing the functional loss which they have incurred because of the cancer treatment or therapy which they have undergone. And obviously we have to motivate them to get back, we have to uplift their spirits, and a lot of motivation required because they're kind of down and depressed with the things happening around.
That is true. Now, I was asking because we constantly read about the value of exercise as a part of overall cancer treatment. So, um, clearly, it makes a difference even in oral cancer. Sometimes it's more difficult to see the connection, when they talk about general health affecting the overall outcome of cancer. You can think of it say, in relation to other parts of the body, but in some ways it becomes difficult for people because I get asked that sometimes, how can it help with oral cancer? I mean, something that people keep forgetting, that the oral cavity is basically a part of the same body, so
Out of
there
the
is
same body.
connection. Yes. So that is one thing. Okay, one of the things that even I have always felt is, how difficult is it for people who have gone through cancer treatment to get their normal speech back?
Depends on the type of cancer which they've got. If it's a glossectomy which we are looking at, like the resection of the tongue which we are looking at, then if it's a partial glossectomy or a hemiglossectomy, I have a lot of patients whom we have kind of pushed along with speech and swallow therapist to get their speech back. I had a patient back in Belgaum only who used to initially call me, and I was not able to understand or perceive what he's trying to talk. So he used to give the phone to the daughter and tell that, sir, can I come today for therapy? Just checking on whether I'm available or no. And then gradually over a month's time, he started talking to me on the call. And so it depends on the therapy, and it depends how much the patient goes home and works on himself or herself. So the therapy would take around 45 minutes to 1 hour. Along with that, if the patient is actively doing the things which we have suggested, like for a patient with glossectomy, exercises along with more of talking or reading or singing, chanting, all of this helps to get the tongue function back to normal. So we can say for a approximate period, and especially for a patient with glossectomy, I would say 2 to 3 months is a time frame which we are looking at to give your answer.
That's very nice, but that basically means there is definitely still hope, because especially for patients with glossectomy, we don't really know. But this means there's a lot of hope there, and
Oh,
that's good.
yes.
Yes. We have another comment. Dr. Anjum says, how soon can we initiate physio after the problems pop up or after the surgery?
We can initiate in, what is he mentioning? Pop in and or
I
after
think
the
basically
surgery?
she means, do we wait for the problems to start, or do we start right after surgery?
No, I think we can start right after surgery. In our setup, I usually get a reference immediately on day one of surgery for maintaining the chest hygiene. We start with chest physiotherapy. We start with making the patient sit at the edge of the bed if early mobilization is not facilitated for the patient. But usually we go for early mobilization also. Early mobilization, as in we try to ambulate the patient as soon as we can, looking at the hemodynamic stability, looking, we get an approval from the surgeon whether we can mobilize the patient or no. So I think POD, I think she means. So it's POD day one. I would start with the rehab of any patient post a surgery.
Right. Okay. Now you're talking about a chest hygiene and what are the expected problems after an oral surgery, after oral cancer surgery in terms of chest?
In terms of chest, we look into it because the patients usually or sometimes are intubated. So what happens is the clearance. There's a lot of mucus which is generated, and the mucus is not cleared because the patient was on ventilator. So we try to clear the mucus. The mucus plugs have to be thrown out, and the chest has to be clear, and the lungs have to be inflated properly back, and so that the patient would be off the venti, the patient would be off extra O2 which the patient is requiring. So that is a chest hygiene which becomes of prime importance. That has to start from day one post-op.
Yes, that is. Okay, we have one more from Professor Hiller. Yeah. Can one rewire the brain after major resection to compensate for loss of function?
Depends on which rewiring are we looking at and which part of the brain is resected.
That's true. I guess that's what what Professor Hiller might be pointing at is that can we again we have lost us. It's like speech. You said you've lost the function, but constantly exercising we have there's research which says that the within the brain the there's sort of a rewiring of connections that were lost, and sometimes new connections are formed to bring about the same
Mhm.
function. So that, I guess, that's, yeah, it is very interesting. We also have one from Dr. Jadhav. An alkaline diet and alkaline water is something people are being suggested. Does it make any difference in rehabilitation or post cancer phase?
I'm not aware about the alkaline diet. I've heard about alkaline water being used because of its pH, and I feel it's kind of a gimmick which they are using as a marketing strategy of, because our body itself has a, sorry, excuse me for that. Yes. So I think our body has a mechanism in which the body just kind of deals with the acidic content and neutralizes it, and it neutralizes the content already. So we don't need any form of alkaline water or a diet which would help us. And what does he say? Does it make any difference in the rehab? No, I feel the rehab remains the same if there's a dietary modification, or if we are talking at post cancer phase. No, the rehab would not hamper or change for them.
Yes, I agree with you, and I can add that definitely the body is very well equipped to overcome acid, in the sense to buffer acid back to normal, which is where we want to be. We don't want to be alkaline, maybe very slightly, but we don't want to be at an alkaline level.
Alkaline
So
levels,
that is
yes,
actually a system that's very well, very effective. Yeah.
affected.
Yes, you are welcome, Dr. Jadhav. Right. So, okay, I think we have dealt with all the questions and all the queries, and we are well in time. Okay. So, anything you would like to say as a last comment to
As a
sum up?
closing, yeah. So, as the slides also mentioned, that we would want to enhance patients with rehab being a part of their daily routine, and making rehabilitation as a part of as a part of the cancer treatment modality also is what we are aiming at. So more and more rehab perspectives, more and more physiotherapists come into this, and we would like to make the community bigger and bigger day per day.
Yes, definitely. And I have to also say, I do definitely hope that more and more dentists also become aware. And because at the end of the day, there will be a dentist involved, even if not
True.
directly in the treatment of the cancer. There is normally a family dentist, and patients would probably not be regularly going back to their oncosurgeon, but will be going to their dentist. And I think it's
Dentist.
very important that the dentist keep on, reminding the patient that they need to continue with their physiotherapy and to be able to guide them to the right person. Yes, that also makes a difference. Okay, friends, I think we are done with all this, with the discussion. Of course, please don't go away. Like I have to say, did I say actually? I forgot that we have some important news, and I request you to stay till the end. In the meanwhile, let me first say thank you to Dr. Rushil. It was a pleasure having you here and listening to you, and very informative. Thank you.
Thank you, ma'am. Thank you for calling me.
You're most welcome. We will definitely be calling you back.
I'm happy to be a part.
Yes, you're not off the hook. You're definitely coming back.
Sure.
Yes. Thank you so much again. So let me go on and share some of the news that we have. So, right. Last time also I mentioned we have an open mic that is happening on for which we have two live events. It's going to be a competition, and the two winners of the respective live events will be among the guest speakers that will be invited for our upcoming International Oral Diseases Case Presentation Conference. And so you will be sharing the stage with a number of experts from around the world. You can check out what happened in our last conference on our website, that is at oralpathology360.com. Go to the conferences tab. You can see what happened in the last conference, and then you will know what to expect. In the meanwhile, the reason why the open mic is there, as you know, we are focused on having equal opportunities. So I know there are a whole lot of young colleagues or even mid career colleagues who may be thinking they're ready to be hitting this international stage, but maybe the opportunity is not turning up. So the idea is to give everybody the opportunity. If you go to the website and you look, you will find the link. It's on the homepage itself. Click on it, you will go there. There are two events. Remember, you have to give your submission. Uh, of an abstract of what you're going to talk about. The topics are pre chosen to keep it sort of an even playing field, but you can find all the details on the website. And remember that our channel members, that is, those who have joined our channel from YouTube, get a special discount. Anyway, go have a look, find out the details, and it will be lovely if you take part or if you know someone who would like to take part. And yes, we also have a new member to welcome. We have Dr. Vandana Shah, who's joined our membership. Thank you so much, Dr. Vandana, and for your support. Now, this support and what I would say the other, as you know, the majority of our content is free. Everything on the channel is free, with the exception of what we have just started creating an atlas, a clinical pathological video atlas of diseases that will be a researchable uh, database, and that should help a lot for everyone who wants to just look and see something. So for that we have got this membership set up. It will be a small monthly amount, gives you a whole lot of perks, but also helps us to go on with this. I do hope that you can do this, you can join. If not, just enjoy watching, no worries at all. And oh, Dr. Anjum, I do believe Dr. Rushil is gone, or is he here? Dr. Rushil, are you here? We have another question. Oh, yeah, all right. Excellent. Okay, let me bring you back. Yes. Okay, we have a question, I think. Yes. Dr. Anjum says, what do you suggest about visceral manipulation post op? As we know, it's closely related as well. So, do you suggest this for speech as well as working on specific muscles?
Yes, I'd suggest that we can go for a visceral manipulation, but depending on the case and obviously depending on the type of cancer, if we are looking at the visceral manipulation for just for the fascia or just for the oral cavity, we can surely go for it. But being it for a case like the patient has a history of tongue resection, like a hemiglossectomy or a partial glossectomy, I feel that visceral manipulations would not play an important part. So that would be my go on visceral manipulations.
Right. Thank you for that. So, okay, nothing else so far.
Thank you.
Thank you. Thank you. Let me also continue with this. And right. So, going on with announcements, we have a new program, and that is Interactive Journal Club with Authors. This is going to be once a month. It is going to be specially hosted by Dr. Puyan Amini Shakib, and many of you may know him. He has been conducting a lot of very interesting programs in the last few years in the COVID times, and now he is joining us as the host for this event. It was anyway his idea, and it's entirely his show. I do hope you will be able to join us. Do not forget, now this is not on Tuesday, this is on Saturday, and the first one is going to be this Saturday. The co author for this, who is going to be there, is Dr. Baloch Zubair. Two young residents will be presenting the paper, and then there will be a discussion with the author and, of course, all of you. So make it a point to go to the channel and place a reminder. And we also have, yes, on Tuesday. Now, coming back to our regular program, we have another dentistry special, which is ethnodentistry, New Frontiers in Research. This is going to be talking about using some of our more traditional medicines and herbs in dentistry and how to actually conduct research. Because, as you know, we need to be able to have proof for what we are going to use. And this is going to be this lecture, and this discussion is going to be to tell all of you how you could conduct such research by someone who is very much involved and who's doing a lot of work, by Professor Sharda. Then let me see, I think I saw another comment. Yes, Dr. Rishin. I'm going to keep bringing you back. Right.
Sure. Tell me.
Yes. Okay. Dr. Vivek is saying, respected Sama, how can patients from non metro cities avail the physio help where experts are not available?
That's a tricky question to manage. But to Dr. Vivek, I would suggest that getting getting the patient to a nearby metro city, whichever was feasible for him or her to bring the patient to, or getting in people to the city with specialty, I would say. And the last option available, which COVID has taught us, is doing online consults, which can help us. But being it from the physiotherapy point of view, exercises can be taught over the phone or over the video, but doing any procedure or doing a release technique or helping with other modalities would not be possible over the phone. So getting yourselves expertised into it is one option, I would say.
Yes, that is. But actually, I think, sorry, at the moment in India, we have a fairly large number of physiotherapists.
That's true.
Our numbers have
And
increased.
numbers have increased, and we as we as in the institute HCG has a widespread of hospitals in and around India. So we have in smaller centers as well. So if the patient is coming from a cancer background, he or she will be knowing about HCG, I'm sure.
True. And another thing, just before we wrap up, I think it's time. Part of the reason I organized this was to get everybody to realize that the same way we generally have connections, we establish connections with colleagues in other disciplines because we need to have people to refer to.
Happy.
We also need to go looking out and find a physiotherapist near us. You know?
That is true. So, as we have a local physician whom we refer the patients to or whom we go to
Yeah.
regularly, we have a common dentist. Okay, this is my dentist, this is your dentist. Similarly, we want the culture to be developed for physiotherapy as well. As in, we have a to go physiotherapist who is helping us with, let it be a geriatric parent at home or a grandparent at home, let it be a pediatric. So maybe not a center as a whole, but a physiotherapist or a team of physiotherapists who can help us with all of it.
Yes. And in the process, you can also very often help with the dentists themselves who are very commonly having back problems.
Back problems and upper trapezitis. That is
Yes.
the commonest problems I get from all the surgeons. They have a lot of
Yes.
trapezitis issues because of standing for a long hour, having a bent posture for a longer hour. So
Yes. So all in all, a good idea to go searching for a physiotherapist near you.
true.
In Belgaum, we are lucky we have a whole college.
College, yeah, yeah.
So there's really no shortage.
And they have all the available departments also. They have
Yes.
like 11 specialities available, all
Yes.
of them having their separate OPD. So
Yes, that is true. So it's a good thing, but I can understand if you're in a smaller city where it's not there. But well, it can't be helped. Okay, so we had a lot of discussion, and you answered a lot of questions, and I didn't let you go.
that's okay.
Right, but now we are really at the end. So I shall say bye to everybody and looking forward to see you hopefully on Saturday, otherwise on Tuesday, and definitely looking forward to seeing you again, Dr. Tanna.
Sure. Thank you
Bye.
so much.